So good afternoon, everyone. My name is Ashenafi I'm from the African Society for Laboratory Medicine. In the interest of time, this is special COVID-19 session number 52, where we have dedicated this session to really take a step back and take stock of what has really happened, particularly with trying to increase access to diagnostics with respect to introduction of rapid antigen diagnostic tests, which have really been a game changer in trying to diagnose SARS-CoV-2 as much and widely as possible within our settings. I would like to call upon Dr. Aytenew Eshete from the Africa CDC to give us a few remarks before we begin our session today. Thank you.
On behalf of the Africa Union and Africa CDC, I am pleased to welcome you to the ASLM special COVID-19 session number 52, and where we will be sharing experience in regarding to increasing community access to COVID-19 testing services. Testing is a critical cornerstone of COVID-19 response. In 2020, the Africa Union Africa CDC launched the partnership to accelerate COVID-19 testing, what we call it PACT. As of 14 March 2022, more than 101 million tests had been carried out, and more than 11.3 million cases of COVID-19 have been detected in 55 member states. More than 14 million antigen testing conducted in 28 member states alone. According to the WHO Regional Office for Africa, 85% of COVID-19 cases remain undetected in the continent. Despite all efforts to scale up COVID-19 testing in member states, including a wider use of antigen RDT tests, accessibility of diagnostic testing still remains an area of improvement. Furthermore, the recently emerged and rapidly transmissible Omicron variant could make the situation more challenging. As with a symptomatic infection, the wild symptoms from the infection be variant of concern such as Omicron may further contribute to an increase in the number of infected people who do not seek testing or medical attention. As a result, a need of intensifying COVID-19 testing in Africa Union member states using all existing testing approaches, including antigen RDT. This only can be increased the current coverage of COVID-19 testing with linkage to the treatment and also self-isolation. Africa CDC appreciates the tremendous support from all stakeholders who have been contributed and continue to support COVID-19 response. We acknowledge Ministry of Health of the Africa Union member states, WHO, ASLM, UNITAID, the Global Fund, CHAI, AFNET, Last Mile Health, AMREF. We may not mention each and every partners and funding agencies here due to the time constraints, but Africa CDC acknowledge each of you. Overall, countries are strongly encouraged to focus antigen RDT deployment through community-based intervention that target case detection amongst individuals with symptoms or a known exposure, with the goal of decentralizing COVID-19 testing services. Support systems are also critical to maximize the impact of antigen testing services. In today's session, we are privileged to hear experience from some of the training of trainers, sharing their experience from Nigeria and South Africa. So welcome to the session. Please feel free to ask as many questions as you can and pick out some very good lessons that you can replicate in your countries, as well as strive to increase coverage and access to COVID-19 testing services in our community. Welcome again to this special meeting. Thank you. Thank you, Ashenafi, back to you.
Thank you very much, Dr. Aytenew, for the wonderful remarks. Let's move on to our first presentation, which is going to come from...
Yes, Catherine, yes, we can. Thank you.
Okay. Good afternoon, everyone. So I'm Catherine Okoi, and I'm the COVID-19 Laboratory Technical Advisor for NCDC. And today we are going to be sharing our experiences when we look back at increasing community access to COVID-19 antigen rapid diagnostic testing. So just to give a little bit of background, okay, so just to give an overview of Nigeria, it's a country located on the west coast of Africa, and it operates a federal system of government. As you know, we are the largest or most populated nation in Africa with a population of over 200 million persons. And our life expectancy as at 2020 is 54.81 years. And then the investment allocation for health, it's about 5%. And as at 2019, our J score was 46%. And of course, I just want to state here that COVID-19 is not the only disease we respond to. We also have other outbreaks which occur from time to time, like Lassa fever, Ebola, meningitis, influenza, and monkeypox. We respond to. So just a little bit about the NCDC. It is Nigeria's National Public Health Institute, and it's actually charged with a mandate to protect the health of Nigerians from the impact of communicable diseases of national and international health importance. And the NCDC does this through evidence-based prevention, integrated disease surveillance, and other response activities while using a One Health approach. And this is really guided by research. And of course, the research is led by a skilled workforce. So I've provided here our NCDC website. You can go there at your own time and then read all the other activities the NCDC is involved in. And so how do we work? We do not work in isolation. We have at the subnational levels a network of state epidemiologists, laboratory focal persons, disease surveillance notification officers that we work with. And of course, as I've said, we operate under a One Health approach. Therefore, we work with national institutions, and we have numerous partners who are always there to support us in the activities we perform. And this is a well-familiar slide, just to state here that, I mean, the pandemic was declared in March 2020, and it has affected over 200 countries, including territories. And as at now, we have over 400 million persons confirmed worldwide for having COVID. And the case fatality rate as at 8th of March is 1.3%. And what do we have in Nigeria? So just going through it briefly, in country, we have tested over 4.5 million persons, and this is by rapid diagnostic testing and real-time PCRs. We have over 200,000 confirmed cases, and of course, our case fatality rate as at yesterday is 1.2%. So just like any other country or most other countries, we have gone through 4 waves of the pandemic. What is really important to note here that the last wave we had was not as deadly as the first 3 waves. And so looking at our testing trends, both with real-time PCRs and rapid diagnostic testing, we can see we started the rapid diagnostic testing in EPID week 45 of 2020. And we went through all through this while we've been testing with RDTs. You can see the peaks in testing with huge numbers of RDTs. And as at week 9 of 2022, we've actually had more RDT testing than the PCR. So I'll come to this slide later, but this just shows where most of our RDT testing is done in a group of persons who usually undertake the NYSC National Youth Service Corps activities. And so that was just a brief background about the holistic activities in Nigeria. I will now go on to our implementation strategies and share with you the challenges we've had so far and experiences. So sometime in September 2020, after the WHO announced emergency use authorization for antigen rapid diagnostic test kits, actually for Abbott PanBio and the SD biosensor, in country here, we now had application and field performance assessment of the rapid diagnostic tests, which were approved. And this was also done using the NYSC group, which I just mentioned. Thereafter, we went into development of guidance documents, algorithms, and also piloted the use of the RDTs in 5 healthcare facilities. The experiences that emanated from this was then used for further deployment and scale up of RDTs in country. And up till now, we are having ongoing scale up and ramping of testing. So what actually is the scope of our work for RDT testing? Basically to scale up visual antigen RDT testing for SARS-CoV-2 in the 36 states we have in country, including the Federal Capital Territory. And of course, this was supposed to be used in healthcare settings among contacts of PCR confirmed cases and in congregate settings, including semi-closed and closed settings. And we also needed to provide knowledge and train persons on the appropriate and safe use of these kits so that while testing, they can make available reliable, reproducible, and accurate results that will be used for proper management of patients and also for making public health decisions. And what are the target settings we really look at? We have schools with accommodation facilities. We look at office and workplaces, and of course, healthcare facilities where we test all this group of persons highlighted. And again, we test in prisons and other similar congregate settings, such as all the IDPs and land borders. And so for our operational strategy, we actually engaged in a seamless manner responsibilities for stakeholders. We also built capacity for those who are training and even those who are doing the end user testing. We also have a strategy for deployment and another strategy for stock management of our commodities. And then for us, data management is critical because, I mean, if you do all the testing and you don't capture any data, and then you wouldn't be making any decisions on what you have worked on. And so for data management, we take it really seriously. We provide all the tools that are involved in data capture. We also train and ensure that we use the national database to impute all the data which emanates from the testing. And demand creation is a critical and very important issue here because we know testing is really going down across the world. So there's a lot of demand creation to ensure people are aware. We do advocacy to states. And then not just testing, we ensure that once you're tested and you're positive, we are able to do a case, follow up with case investigation, contact tracing, and also link testing to care. So for this, we have a national algorithm. And what is really important here is to note that we complement the RDT usage with the real-time PCR. So for example, if you come to a healthcare facility or if you are tested anywhere and you are having symptoms of COVID-19, once your RDT is positive, in Nigeria, you are managed as positive. However, if it is negative and you show symptoms that are suggestive of COVID-19 or other respiratory ailments, your sample is collected and subjected through PCR. The PCR now becomes a tiebreaker to give us a result from which we can continue management with. And so I mentioned capacity building. So once COVID broke out and a WHO approved the kit, made sure there were emergency listing, there was capacity building by African CDC and ASLM where 3 persons were trained in Zambia. And once the 3 persons came back, that included myself, we ensured we now put up a plan to cascade the trainings in country. And so for this, we worked with colleagues and made sure the trainings were implemented geopolitically. So in Nigeria, we have 6 geopolitical zones, as you can see on the slide, and these are the dates in which all these trainings were implemented. I just really want to say here that this was hugely supported by all the partners you see on the slides. And later on, we'll be looking at figures. And so once the zonal trainings were implemented, we also now supported the states, again, in collaboration with our partners. We made sure the trainings are now cascaded in the state. So as we speak, we have had step-down trainings conducted in 23 states, including or plus the Federal Capital Territory. So just looking at the summary of healthcare workers trained in countries or who have been equipped with the skills and knowledge to effectively deliver these trainings, we have 1,350. Of these, 74% or 72.4% of them have been certified, which means anytime we want to have a training wherever, we pick from this pool and implement trainings. The 25.8% who have not been certified are usually not used for trainings. However, when we want to implement testing, this pool can also be readily available. So looking at where we have activated RDT testing so far, you can see the numbers here. As at yesterday, we have a total of 32 states which have been activated. Of these 32 states, we have so many different sites, up to about 300, which are now testing using RDTs. And also we have over 1 million tests which have been done, and our positivity rate using the RDTs alone is 1.7%. Now, we know that the RDTs are simple to use. They can be used at point of care. Make sure results are generated in 15 to 30 minutes so that patients can be appropriately and quickly treated, and those who are positive can be isolated. Yeah, it looks really easy. However, the implementation has also come with challenges. For example, we have low uptake by states due to the fact that, some governors are simply not really interested. In the states, people also have a poor perception about the disease. And of course, we are in a situation where we've been responding to a pandemic for almost 2 years. Healthcare workers are simply tired. Then we have suboptimal data capturing, resulting in data gaps in many states. And this is an area we really need to improve on. The logistics also is not where we want it to be. People test, they don't impute data, they don't submit utilization reports. So it is really difficult to manage the logistics. And even with the logistics, we have now included sequencing of positive samples from RDT testing. However, how do we transport these positive samples from the site to where they need to be sequenced? So this is also an area which is a huge challenge for us. And you've also seen that we have quite a couple of partners who are supporting us and doing the, making sure all these activities are effectively and efficiently implemented. However, the coordination is not yet tight. So this is another area where we have a challenge and we are trying to work on as a nation. So just going forward, the thoughts we have as a nation is to strengthen our coordination and scale up, of course, with the partners involved. And then some time ago, colleagues at the ASLM know that there's supposed to be the preparation of a reference train for quality assurance for testing. This didn't go through very well. So we are at a situation where we use supportive supervision for the activities. But going forward, we would really want to have a reference train where we can share to the site, and this is completely standardized so that everybody is working at the same level and implementing quality assurance to ensure reliability and authenticity. And again, I've talked about the positive samples. Then moving over to data management, we want to really ensure data is captured in real time, so we continuously engage with the state surveillance officers and the epidemiologists, with the laboratory focal persons to ensure this becomes a reality. And demand creation is something we are also currently working on to ensure that this is hugely fulfilled. And then linking diagnostics and vaccination strategies, we are also looking at areas where if there are vaccination campaigns, we could also include diagnostic testing. Because I just explained how the NYSC is the largest population where the RDT are done. So if we also use the vaccination strategies, I think we can equally scale up testing to a huge extent. And so in conclusion, I would really want to say here that this is a continuous activity, and at any point in time, we need to involve all the stakeholders at the local government level, state level, and at the national levels, including a partner, be it internal or external. And of course, partners, again, there's really need to strengthen partner coordination so that there's no fragmentation of activities. Then ensuring that data is captured in real time for appropriate management and for making control strategies and public health decisions, it's critical. We cannot overemphasize that. Then the last thing I want to talk about is a training module. So for the TOTs we implement anywhere or the end user trainings, we use the ASLM training modules which were handed over to us while we were in Zambia. Once we came back to Nigeria, we start as a team at the NCDC and ensured we tweak them around and contextualize them to the Nigerian system, as you have seen on our national testing algorithm. However, we are currently reviewing our testing strategy, and once that is done, we would want to review the training modules and ensure we include every activity that needs to be included on the training module, so that when we go to the site, be it a TOT or an end user, we make sure we are able to deliver effectively to the persons we are training. And so now we are talking about COVID-19. For me, what really matters is how prepared are we to handle any pandemic that comes our way, because this is not the last pandemic we are going to be having. Are we appropriately prepared? Can we, at any point in time, if we have a pandemic, detect, prevent, investigate, and in real time provide data that will be used for management of the cases and for making appropriate decisions and putting in control measures to ensure this doesn't become a widespread pandemic as COVID-19 has shown us. So these are some of the thoughts and lessons and thinking through activities we need to put in place. So now we would also want to leave you with this website. This presentation is really short, 15 minutes. It's just not realistic to capture all the plenty activities we've implemented in country. So we are leaving you with some websites where you can go to and see what is happening in Nigeria. I would like to finish up by just saying a very huge thank you to all our partners who have always been there to support us in this activity, and for the trainings, the end users, they've supported with logistics. You saw WHO, USCDC, Institute of Human Virology. I can't even mention all, and ASLM, who trained us and also made sure these trainings are correctly implemented in country. And of course, up till tomorrow, they still ensure whoever is trained and it passes the test can be certified. They always follow up to provide certificate for those, and people really like to have their certificate. So thank you so much. And I also want to thank our colleagues who have connected to this webinar. Everybody is really so busy, but some of you have connected to ensure you listen to me. Thank you. And thank you everyone for being there.
Thank you so much, Catherine, for sharing the Nigerian experience. Colleagues, that's the experience from Nigeria. And like Dr. Aytenew from Africa CDC said, it would be great if we take some of the good lessons from Nigeria and we actually replicate them in the different countries where we are staying and working. So colleagues, that has been our colleague, Catherine. She's a medical lab scientist who's working with the NCDC. And thank you so much, Catherine, for the great presentation. Colleagues, if you have any particular questions you'd like to ask or clarification, feel free to put them in the chat. And also, just to inform you, we have in the post from Africa CDC, there is a link to the recently released self-guidance for COVID-19 self-testing. Please feel free to download it such that you acquaint yourself with the content. Colleagues, our next presentation is from our colleague Lynsey, Stewart-Isherwood from South Africa, who is a public health specialist. And she's going to share with us the experience of how South Africa has managed to roll out COVID-19 antigen testing in the country. She has over 2 decades of experience in TB, and she has been involved in this fight right from the beginning. So, Lynsey, feel free to share your slides and go ahead and present. And sorry, we don't have much time. We have about 15 minutes. Share your experience with us, such that at the end of it, we're able to have some minutes spared for the questions and answer session. Over to you, Lynsey. Thank you.
Thank you, Eshete. And I echo my co-presenter's sentiments and thanking everybody for taking their time out today. Thank you to ASLM for providing us this opportunity to present to you today. And I'm very humbled to be chatting to you today on behalf of the National Department of Health and our provincial departments of health, as well as all the hard work from our colleagues from the National Health Laboratory Service. So first of all, I'd just like to give you background to the COVID situation in South Africa. We have molecular or PCR tests happening, as well as the rapid RDT test happening. And we have over 16 HIV viral load labs that are doing the testing of COVID, the PCR testing, and we have gene experts as well. To help us increase the access to community testing, we also have 60 mobile laboratories that are around our borders conducting the antigen testing. And of course, we have both NHLS and DOH testing sites. I must make a disclaimer that I am presenting the testing training on behalf of the public sector, which accounts for 80% of our population. So to date, South Africa has conducted over 23 million tests. This is PCR and RDT tests combined, with the RDT test to about 10.6 million that constitutes for that amount. We've had a total recoveries of over 3 million, and currently we have over 20,000 active cases. But I'm pleased to inform you that over the last 20 to 48 hours, as from yesterday, we have had no deaths over that period of time. So not only are we involved in the implementation of the antigen testing training, but we also work very, very closely with our research and diagnostics group. That is Professor Leslie Scott and her team from the Department of Molecular Medicine and Haematology, that is headed by Professor Wendy Stevens. And right at the beginning, I'm giving you feedback from 2 years ago. We were involved in the evaluation of hundreds of tests, not only antigens, but serology tests, as well as RT-PCR tests to try and combat this pandemic. And you'll see, just focusing on the antigen testing, that we had completed over 55 antigen evaluations, and 39 were actually approved at the end through our SARPA regulatory body. So you can see, concentrating on antigen tests, of the 55 we completed, we had over 51 in 2021 and 4 in 2020. The 3 were actually local manufacturers and 59 were from international manufacturers. And we had different types. We had chromatographic, we had fluorescent and automated tests come through us. So I'd just like to acknowledge this team. It was a lot of work that was put into this, and working closely with SARPA. It also meant that we had to come up with our own protocol for these laboratory evaluations of all of these tests. And I just wanted to share with you the intensity behind the evaluation of these kits to get approval, and just illustrating to you that comparing to the CT values, you can see the high viral load with low CT values and how these tests performed across board. So, as my fellow co-presenter Catherine also emphasized, the data collection and data management is absolutely critical. Now, for all of our national programs and for our laboratories, we do have a national connected system where all of our laboratories are connected to a central data warehouse. And this is how our data is captured and analyzed. And this is no different for our COVID-19 pandemic as well. NHLS have designed a COVID surveillance application, and this is used to collect all the testing data from the antigen RDTs in the field. And this is how we centralize the testing data in the public sector. So going back 2 years to January 2020, when we first started implementing the testing in South Africa, we did start with the ASLM training materials. And if you focus on the right-hand side here, you can see what our overall strategy was at a high level. So we had master trainers from our national priority programs first trained by ASLM. Then our master trainers went out to the field and tested train of the trainers. And we targeted our National Health Laboratory Service colleagues, and we empowered them to be able to go out into the field and train our end users. And this is what they did. And then through the ASLM program, we managed to provide both TOT and end user certification through ASLM. But our TOTs also received WITS CPD points. This means that our University of the Witwatersrand has accredited the ASLM training course too, and thus our trainer, the trainers could receive CPD points. But I wanted to allude to you how important it is when you deliver the training that your training needs to be engaging. You have to facilitate the training sessions that will equip the end users to conduct the training successfully. You need to include your local best practices. And we did that by including our South African algorithm too, our testing algorithm. Your practical exercises must be conducted in a safe environment and include as many videos as you can and practical activities. In fact, some of our NHLS colleagues actually developed their own videos, which helped underpin other videos from suppliers to conduct the testing. And it was received very well. Competency assessment, of course, for the sake of our quality of our testing, we have to ensure that when we train our end users, that they are assessed for competency. We cannot stress enough, that was one of our lessons learned, is that quality control needs to be emphasized upon when we conduct the training. And of course, we have to continue to review local protocols together with international protocols to make sure the training materials are in line. And then to continue taking our precautions around COVID-19 when we conduct the training. So our roadmap from January to September last year, this was just setting the scene for the training. It's using the ASLM antigen testing, is that once our master trainers were trained, they went out into the field and they trained train of the trainers, mostly our NHLS colleagues, but some in the private sector from the mining industry too. And then these train of the trainers went out and trained the end users. But before we went out, the train of the trainers had to go and adapt all of the training materials to suit the South African environment. And our R&D department, with their experience with all the evaluations, they took 2 of the test kits that were in the field at the time, and they developed videos to support our training materials as well. And evaluation of this, the area managers were notified to bring to provide delegates to be trained. These are the train of the trainers. So we work very closely with our NHLS area managers and our business managers to get the end user training out. And then we broke them down into 3-hour sessions for Thursday and Friday for the month of February. Then we had further sessions that were conducted in the field with the Department of Health. And this is going down into the granular level, but for the practical, we had 2 practical activities for sample collection, 4 practical activities to demonstrate the RDT testing, and then we still had the theory and practical assessments. So it's quite intense to make sure that all the end users were competent. And so the target audience for the TOT training were actually our senior lab managers, lab supervisors, quality manager coordinators, senior medical technologists, as well as Department of Health healthcare workers. And then they had the end users in target, which was the NHLS DOH healthcare workers. And then we continue to work closely alongside the National Health Laboratory Service and the ASLM and the National Department of Health to support their training in the field. This was the initial group of master trainers, but since then we've had a whole group of TOTs in the field. I see some of them are on the call today, and I just have to thank them. We cannot underestimate the hard work that they've gone through to implement the end user training in the field. Our initial blast of training up until the end of December last year, you can see that although we only stayed 366 end users, 335 that were certified, the numbers have increased of late because we continue with our training with the NDOH. You can see in December, to address the 4th wave, we actually trained 1,500 healthcare workers hosted by the National Department of Health Knowledge Hub. And it was in December that we officially co-branded all our training materials with National Department of Health, ASLM and NHLS. We are working with a partner, CHI at the moment, who are now rolling out the training to tertiary education sites, which is aligned to all the vaccine strategies as well. And then the NDOH have just started a whole new training program targeting a further 900 healthcare workers, targeting 100 in each province. That has now started this month as well. And our fellow NHLS team members continue to train end users in their provinces and districts as well. So just to give you a visual, these are our mobile testing labs. And you can see that they were located strategically along our borders, and to date they have contributed towards the total number of 3 million antigen tests, and that's 874,000 of those. And our testing locations are either fixed facilities, that means in laboratories or clinics, as well as mobile vans, which is reaching our communities and borders. Our data capture tools, our NHLS testers use TrackCare, and CSA is the COVID surveillance application designed by NHLS to support the mobile vans, as well as the Department of Health and our tertiary education testers. The CHILD project, this is what's happening in the field at the moment. This is to expand the use of antigen testing to non-health contexts, such as students. And to date, they have trained 106 healthcare workers at 19 tertiary education sites. And at the moment, 195 tests have been conducted. But I wanted to display to you a different way of illustrating you the distribution of our testing sites against our population density in South Africa. You can see here the red dots indicate where the tertiary education sites are busy testing and using the CSA at the moment. And the blue dots indicate the Department of Health testing sites, and the green dots indicate where the National Health Laboratory testing sites are. And you can see that it's quite evident that the more populated the area, the more volumes of antigen testing are being conducted. And of course, Northern Cape is, the Northern Cape is very dispersed. So the population density is not as high as your urban areas here. And again, this is with thanks to Professor Leslie Scott and her research team. We thought we'd present to you the positivity rate of both the antigen testing and the PCR in a different format. If you look at the top graph here, you can see that the turquoise is actually the negative results, and the red is the positive results of antigen testing. And then the blue line here are your CT values. We wanted to illustrate to you how important it is to monitor the CT values across the pandemic, because we found that using CT values, you can see here our different waves, our 4 waves happening here, that if you monitored your CT values, and CT values, of course, the lower your CT value, the higher the viral load, you can start predicting another wave coming in, and you could see that. But in between waves, how important it is to actually monitor your CT values of the virus. And we found in South Africa that it's most optimal to have a CT value of 30 when it comes to the efficacy of the antigen tests, or the performance acceptance criteria is a CT value of less than 30. And in the bottom graph here, you can see the positivity rate. Of course, your PCR positive rates are higher than your antigen, of course, because it's far more sensitive, your PCR tests, and they would pick up a lot more positives. But this too gives you a clear indication of the positivity rate across the 2-year period that we're looking at to date. So I just wanted to point out again how important and how valuable antigens are both during the wave and in between the waves to monitor for surveillance purposes. And of course, they're accessible in urban settings as well. They're much easier beyond the urban settings. We're also pleased on behalf of the National Health Laboratory Service, LIMERA, to let you know that the LIMERA instruments are now being implemented in South Africa. The training commenced today. So we're just saying, I'm pleading with you to watch the space, and we'll give you more data around the LIMERA stats the next time we have an opportunity to talk to you. So some of our lessons learned, and I reached out to some of our NHLS colleagues, and thank you to Iksan Nordian and Bakiso Latanta for providing me your input too. But some of our feedback is that it is important when you're conducting the training to actually elect a champion for each district. So for example, the NHLS area and business managers were involved in identifying who these champions were. And then you have to really make sure that your ideal cadre of staff, we found, was phlebotomists or healthcare workers to collect samples and medical technologists to conduct the tests. There also needs to be a strong collaboration between clinical and lab staff, as well as your provincial and national departments of health. Additional training and support are needed by specialists. We found that adding specialists into our, well, especially our TOT sessions, that really helped strengthen our training too. However, We do lack centralized data collection tools for training specific data. At the moment, it is very difficult to coordinate the training stats as there are different pillars of training happening at the same time, although the collaboration efforts are very, very strong. So we try our very best without having these centralized tools to collaborate with each other to keep each other updated. And of course, the training should go across both public and private sector. But Mr. Iksan Nudia, from his experience, and he's trained many, many end users, he says there needs to be more emphasis on QC. Definitely in-person training is the most optimal. And when the practical sessions often happen, although these trainees are very used to point of care testing, they are often nervous. And he finds that he still needs to retrain or emphasize the trainees on how important it is to have tidy workspaces when you're testing. PPE for swabbing is now common knowledge for all, so more time should be focused on other areas of the training. The Western and Northern Cape developed their own training videos, and they're really good. I've seen them. Also, a detailed worksheet needs to be standardized across the nation as well for sites. And when we do the training, we don't have fictitious patients loaded onto CSA at the moment, our data portal. And it'd be great during training to actually have fictitious patients so we can demonstrate more in real time what happens with this data capturing tool. And of course, Mr. Kiso Latanta, I agree, nothing beats teamwork. So in conclusion, we had tremendous support from the NHLS area and business managers and the laboratory managers to support the training. We do need a centralized mechanism to collect training specific data. We're already in discussions with the National Department of Health and the National Health Laboratory Services, beginning stages of this to find how we could do this. And then there's a need to ensure that the testing training is carried out in a standardized manner as well. And there's a growing interest to use the CSA as we train. And the testing worksheet, as I mentioned earlier, we need to standardize that and place it into all the facilities. The trainees and testers often need to be reminded to check the sample type. We came across this quite often that we have to keep reminding end users and testers to keep referring to the package insert to see is it nasal or nasopharyngeal swabs. And then communication to key stakeholders for the introduction of new kits to the country and region. We have to make sure that a great emphasis is given on the communication when new kits are launched into our country. And there are so many people I'd like to thank as well, but this is about the crux of it in this one slide. And this just illustrates to you the tremendous effort that happens in the back end and collaboration. And I would like to thank you again for this opportunity. Thank you.
Thank you, Lynsey, for the presentation. I think this is a very good experience you share with us from South Africa. We learn and appreciate that it requires a lot of effort for us to be able to increase community access to testing services. You mentioned a couple of things that also Catherine highlighted, and I think these are some of the takeaway messages we need to take, highlighting that collaborations are very key in this effort, and you highlight the element of competencies. We need to ensure that we make sure our trainings packages are up to date. We need to make sure that people are able to appreciate the different types of samples to use. You also mentioned something that we could possibly take up in other countries, where you're saying it would be good to have champions, training champions, maybe per district or per region. I think this is very, very helpful. So colleagues, in the interest of time, we don't have much time left. There are so many questions in the chat and comments, but for the interest of time, some of these we shall be able to post them during our next, when you visit our website. We should be able to respond to all of this, and we shall have Catherine and Lynsey respond to all these questions. Another experience we've seen from South Africa is highlighting the importance of use of mobile testing facilities. I think this is something that countries can take over. picture shared by, it's very important to actually customize to the Africa CDC up to country level specific materials that can be used for the countries. So this has been a great session, but we are mainly with only about 2 minutes, and we may not be able to answer all the questions, but we have taken note of them. I would like to use this opportunity to request Catherine to please give us your parting shot after sharing your experiences in Nigeria, such that somebody can take that and move with it. 1 minute, Catherine, please, for your takeaway message to the participants.
Okay, so this has been a really interesting experience in Nigeria. What I would just like to say is that the rapid diagnostic tests that the WHO has approved are really user-friendly. They are easy to use, even though people need to be trained. Let's ensure we train as many people as possible to test as many persons as possible. But as we do it, we should also ensure that we put systems in place in terms of quality assurance, supportive supervision, to ensure the results that are generated are reliable, they are reproducible, that they are authentic enough to be used for public health decision-making, even as we use for training of patients. One other thing which is important about the training is we see that the ASLM training modules come with assessment facilities. So we should always ensure we fill the certification forms, because it's once these forms are populated, we have enough evidence that persons are trained. Like in Nigeria, we don't miss it. Anywhere the trainings take place, we capture all the persons who are trained, we capture all the persons who were able to pass the assessments that were done. And we also ensure the overall information is sent to ASLM, and then ASLM also filters it and sends the certificate. At this junction, I really want to thank ASLM for providing the certificates, even though some of them have not come in real time, but recently you started doing that. And participants are always glad when they have their certificates. So the antigens have come to be used. They are not going to go back. We use them in completion with the real-time PCRs to ensure that even if we have a lower sensitivity for this diagnostic tool, once you use them with the real-time PCRs, you are able to complement the 20% which is missed most often than not by the RDT. So please, colleagues, make sure you train, make sure you use, and make sure you report the data. Thank you very much.
Thank you, Catherine, for the parting shots. And Lynsey, just 30 seconds, also give us parting shots as our colleagues jump off to other things. Thank you.
Thank you, Eshete. I'll be very, very quick. I think the most important thing here is collaboration, data collection, and QC. So I think if we get all of that right, it'll be great. And please don't underestimate the work it does take to get the testing training going. Thank you.
Thank you so much, Lynsey. Thank you, NHLA South Africa. Thank you, Catherine. Thank you, NCDC Nigeria. And colleagues, time is always not our ally. We would have more to share and discuss, but we are on top of the hour, 1 minute past, and we respect everyone's time. Thank you for making to the call today. We look forward to joining you in the near future, and we'll be sharing more experiences. We have in the queue other countries that are coming to share their experiences, such that we're able to pick more experiences on how we support our communities to access this service. And please, the take-home message from the colleagues who have presented. Catherine mentioned something very important regarding assessment of these facilities and the people, and the collaboration that has been mentioned by Lynsey. So colleagues, in the interest of time, allow us here. Thank you for joining our session number 52. Please check in your inbox in the near future. We shall be posting our next session, session number 53. And keep the questions coming in. We should be able to respond to them and give you the responsible answers. My name has been and is Eshete Silva. I work for ASLM. Thank you for being part of this audience. We'll stop here and bye-bye for now. Thank you.